Introduce our grand round speaker, Dr. Michael Simoni. Dr. Simoni earned his bachelor's degree at Dartmouth College before completing medical school training at Harvard Medical School, his OBGYN residency at the Yale School of Medicine, and his reproductive endocrinology and fertility fellowship at the Hospital of University of Pennsylvania.
That's a good sound.
Currently, he practices as a fertility specialist at Reproductive Medical Associates of New Jersey. On the side, he holds the position of Vice Chair of the American Society of Reproductive Medicine's Health Disparity Special Interest Group, and is a member of the Diversity and Equity and Inclusion Task Force. He is also the executive producer of Fertility and Sterility on Air. His research interests include health disparities in reproductive care, as well as reproductive immunology. His publications have appeared in top OBGYN journals, such as the American Journal of Obstetrics and Gynecology, Human Reproduction, and Journal of Clinical Investigation, and has garnered press from national media outlets such as The Atlantic. I'll now turn the floor over to Dr. Simoni.
All right. Good morning, everyone, and thank you, Dr. Kanusha, for that introduction, and thank you all at Thomas Jefferson for having me today. This is going to be great, I hope. I hope that I could introduce something, at least, to think about for each and every one of you as we discuss the endometrium immunological landscape and early pregnancy loss. I have no financial disclosures, and for the agenda today, first we're just going to briefly touch on what is going on with the immunology of the endometrium, kind of give you some definitions of recurrent pregnancy loss and recurrent implantation failures, things we look at in early pregnancy and issues there, and then some known immunological etiologies for these issues and other topics in which more research is needed but potentially could also be related. So to start, there are some basic immunology rules to think about as we frame the discussion. One is that the innate immune system responses are generally rapid, do not exhibit antigen specificity, and lack memory. There's an adaptive immune response that is antigen specific and includes primary responses, secondary responses, and memory-driven responses. And that immune specificity relies on lymphocyte education process that distinguishes self from non-self. Like you have to be able to say, this is me, let's leave it alone. This is something that's foreign, that is a pathogen that we should take care of. So if you think about exposure to the outside world, the mucosal immune system is actually the first line of defense against many pathogens. I don't count the skin because that's just more like a physical barrier. There isn't really much going on there. The female reproductive tract actually itself is part of this system and thus shares many of the same similarities. In the GI system, the common mucosal system, there are specialized epithelial cells called M cells that actually take an antigen that is coming through the GI tract and actually pass it through the epithelium into these Pyer patches of T cells and B cells that are able to process the antigen from antigen-presenting cells, such as dendritic cells, and then after that go into the lymphatic system, mature, and come out as plasma cells that actually now have the memory and can supply antibodies in order to fight whatever this pathogen is so that the system just memorizes it more and can do it again next time actually in a faster situation. This is more of adaptive immunity, but there is some innate immunity in there. But in the female reproductive tract, they kind of do all that and also then favor actually the innate immune system. So there are more types of cells, such as macrophages, such as natural killer cells, and specific ones for the uterus that we'll get into later on. There's more dendritic cells and there's more monocytes, things that can actually fight an infection if they just show up for the first time. There also is more of a preference for IgGs rather than IgAs. IgAs are a little bit bigger. IgGs can cross the placenta, as residents may know when they're studying for boards. This is something we have to memorize. IgMs also cannot cross the placenta. Easy way to remember that is IgMs are actually even bigger than IgAs, so it's just like kind of a size thing if you want to think about it like that. But this is kind of what's going on. And instead of being active consistently, such as the GI system, the female reproductive tract actually changes its immune profile with the cyclicity of the menstrual cycle through estradiol and progesterone. So they regulate the levels of cytokines, they regulate the transport of IgGs across the epithelial membrane. They regulate various cell populations, and then they actually regulate antigen presenting in the genital tissues as well. Altogether, the uterus and the vagina are able to modulate their immune landscape and take on different properties and areas of vulnerability during certain points of the menstrual cycle. This is, for example, in the uterus, in the mid-proliferative phase, the mid-secretory phase. You could even see like lymphoid aggregates, for example, those kind of like those Pyer patches in the GI system they aggregate more as the menstrual cycle progresses on. Same thing in the vaginal epithelium. It also is different between the two phases. So this is kind of like how it gets those GI attributes here and there. And we know this is tightly regulated because inflammation can be a good thing, and it is necessary actually at certain points. We know the very initial steps of embryo implantation, the rolling, the apposition, and the adhesion actually is made possible by these dendritic cells secreting inflammatory gradients which affect the epithelium to form this mucin layer on top of the epithelial cells and increase the expression of ligands for adhesions by the blastocysts. And further along in implantation during the invasion phase, so now we have trophoblast and specifically cytotrophoblast and extravillous trophoblast. We know that inflammatory cytokines, growth factors, a complement pathway, that they're all necessary to regulate trophoblast invasion and remodel the maternal spiral arteries for the placental circulation. And this is very different from a little bit later on in the first trimester when this amount of inflammation can actually lead to a response such as a miscarriage. So you can see how during all of early pregnancy, there's a very delicate balance in the female immune system. The ultimate goal is responding to the challenges of bacteria, yeast, viruses without interfering with the events that surround conception, and even responding and increasing at the appropriate time of conception in order to protect the pregnancy and support it as it develops. If this messes up sometime along the way, this could lead to poor reproductive outcomes such as preeclampsia, fetal growth restriction, and other placental issues. But today I'm going to be focusing on early pregnancy issues such as miscarriage and implantation failure. So probably not a shocker to everybody in this room that the incidence of early pregnancy loss is very common, anywhere from 30 to some people think like 40% of women have experienced a miscarriage at some point in their lives. There are multiple risk factors we know about, one of them being age, probably for genetic reasons, and then things like diabetes, obesity, lupus, endometriosis, infections, and many more things. The defined recurrent pregnancy loss is when this happens 2 to 3 consecutive times and you have clinical pregnancies, not just biochemical. Kind of take that into how many people experience those. This is anywhere from 15, like I said, probably like 40 even sometimes. They experience 1 loss, 5% maybe experience 2 losses in a row, and then 1% have about 3 or more. So pretty rare. And I'll even say, depending on who you ask, this definition changes. Sure, you know, in some guidelines, it does say 3 consecutive clinical pregnancy losses in a row, but in terms of when you start the workup, who's going to put somebody through 3 of them? So we usually started after 2 anyway. With the new knowledge of inflammation that is coming out, it's now the belief that there is more to inflammation and miscarriage than we know, and we can figure out that, and if we can figure it out, we might be able to actually really help women who are experiencing multiple miscarriages. Part of the reason we believe this is because there's such a large part of unexplained recurrent pregnancy loss, and we think that inflammation actually has to do with probably a little bit of most of these, so genetic, infectious, endocrine, autoimmune, as well as a good portion of this unexplained that just science hasn't really discovered yet. And even though, so recurrent implantation failure is a condition that we kind of have more in the reproductive endocrinology and infertility space, and that we can really establish with IVF because we know we fertilize an egg at the appropriate time, we're putting it in the right place at the right time, and if we're still not having anything happen, then usually, and we've done this enough times, that we can kind of point at the law of averages telling us that something is wrong with the environment that we're putting it in. Its strict clinical definition actually does not have a consensus. However, since research has kind of changed things and gone along, I realize like this showing general consensus actually is, doesn't make any sense because it's all over the place. But as research and stuff has gone along, we've changed the definition. And really the big thing that has happened more recently is now that we have these euploid embryos and are able to kind of put those back and know that the implantation rate should be even higher. So we think it's somewhere between 2 and 3 embryo transfers, depending on if you've tested the embryos or not for their genetic status. And then actually when you do the transfers, if you're putting them at cleavage stage, sometimes we put more than 1 back in at a time. So if you put back 4 good quality cleavage stage embryos over those 2 to 3 embryo transfers, or 2 good quality blastocyst embryos, potentially both have been tested, and 2 different transfer events, then we would kind of classify that as a recurrent implantation failure. That means not getting to a clinical pregnancy. So either you just had no implantation or just a biochemical. This is actually an interesting study that came out of RMA in 2020. We actually tried to nail down how rare recurrent implantation failure is, because we know these euploid embryos are very good at implanting. We quote about 60 to 70% of the time they should lead to an implantation at least. And if the number one factor for implantation is the embryo, as mostly is genetics, then this question was asking, well, if we did consecutive euploid embryos and kind of take out the genetic factor, whatever is left is hopefully pointing at something is wrong with the environment. So this is showing that we took about 4,400 patients and put them through 3 consecutive euploid transfers if they failed. After they went through them one by one, by the time you reach 3 consecutive euploids, only about 5% of women did not have an implantation at that time. And so it was pretty rare for somebody to fail 3 in a row. So we think really recurrent implantation failure is probably rare. So now let's delve into issues of what we think could be causing some of these early pregnancy issues. And we're going to start with some etiologies that we know pretty much are problems, or at least pretty sure. We're going to go through APLS, hydrosalpinx, endometriosis and adenomyosis, chronic endometritis, and then non-distorting fibroids. So antiphospholipid syndrome is probably the first immunological issue that comes to mind with most of the people here, and that's not a surprise. Are the ones that we test for immediately when people are coming in from that workup. These are a few antibodies that bind to negatively charged phospholipids in the membranes of cells, and also phospholipid cofactors. This then leads to potentially a thrombogenic state, and that's the one we usually think about the most, that these kind of antibody complexes introduce an intraplacental thrombi phenomena that lead then to a miscarriage. The prevalence of these autoantibodies is 3 times higher in recurrent pregnancy loss women than they are in the fertile population, and the incidence that we find among them is anywhere, depending on the research that you look at, 8 to 42%. In addition, though, to those intraplacental thrombotic phenomena that we discussed, there are other things going on now that research has kind of shown, that they actually inhibit cytotrophoblast differentiation. They inhibit EBTs, or extravillous trophoblasts, invading into the decidual and kind of anchoring a placenta and starting the fetal circulation. They induce syncytial trophoblast apoptosis, which you could imagine is terrible. And then they induce maternal inflammatory pathways on the cytotrophoblast surface. Diagnosis phenomenon, you need 1 clinical criteria, 1 laboratory criteria. The laboratory criteria ideally are diagnosed 12 weeks apart, or repeated, 12 weeks apart. And it is okay to test during treatment for VTE if they've already had one of those clinical criteria, such as vascular thrombosis, except for the lupus anticoagulants, which actually, if you test for that while treating for a VTE, the direct anticoagulants actually can interfere with this and lead to a false positive. So that's like the one thing you actually should test for before you treat, just FYI. And in case you didn't know, something that I didn't really understand until I was really delving deep into this towards the end of residency is that when you're doing these tests of the APTT and the dilute Russell venom viper venom stuff, I don't even remember what the whole thing is called, but when you're doing these, you're looking for an extended prolonged time, which is kind of weird if you think about it, because we think of APLS as a thrombogenic state. So why would you get an increase in time, and why is that what you're looking for? It's actually just due an in vitro aspect, and it's kind of doing the opposite by accident. We know it is a thrombogenic state, but the assay itself, just the way it results, the way the lupus anticoagulant interferes with this stuff is by making it longer in vitro-wise. And so if you can imagine, if somebody's already getting treated for a VTE, it's going to also increase their coagulation time, and that's why you get the false positives. Just keep that in mind. There are other antibodies that we test for besides lupus anticoagulant, and that is anti-beta-2 glycoprotein 1 and anti-cardiolipin antibodies, which we'll get into also in a second. So not all autoantibodies are created equal when you're going through these during a workup or evaluation. Anti-cardiolipin antibodies are the most common among people with APLS, about 61% of people that have them. However, anti-beta-2 glycoprotein is actually the one associated with the lowest live birth rates and the highest incidence of obstetrical complications compared to the other 2 alone. You can imagine if you have more than 1 antibody that's positive, you increase the rate of poor pregnancy outcomes. And this is shown especially in women who are triple positive for all 3. It shows significantly higher rates of obstetrical complications compared to single or double positive women. Those who have triple positive have about 30% of chance of a live birth without treatment. Those who are just lupus anticoagulant positive have about an 80% chance of a live birth. But this is something where treatment makes a huge difference, something where research has actually said, oh, we could actually do something about this when women come to us. So heparin actually reduces the amount of antiphospholipid antibody binding to trophoblast and endometrial endothelial cells, also reduces the inflammatory response. So the treatment that can be done is unfractionated heparin twice daily with low-dose aspirin, and now we've just shown that low molecular weight heparin is actually not inferior to this as well and can be used, which is easier dosing and lowers the rates of heparin-induced thrombocytopenia. Unfractionated heparin plus aspirin leads to a huge difference. No treatment alone gets you to a 20 to 40% live birth rate. If you can give those two, you can increase it up to a 74% live birth rate. And even just aspirin alone does something and can give you like a 40% live birth rate, which sometimes is the same, sometimes it's better. And prednisone is not going to do anything. Yes, you're bringing inflammation down theoretically, but that's not what is actually going on pathophysiologically, so it's not going to help. Next up, hydrosalpinges. So normally, fallopian tube fluid is composed of lactate, glucose, pyruvate, potassium, bicarbonate, and water movement is in large response to a gradient that's created by the CFTR, ion channel for chloride. But what can happen over time is that if you get some infection like gonorrhea, chlamydia, you can get scarring or occlusion of these tubes. They release inflammatory mediators. The ion channel becomes disrupted. You get an increase in epithelial secretion. You get a decrease in fluid absorption. And then what also happens is because this tube is now stretched out, the mechanisms of peristalsis throughout the tube are actually all disrupted. And so you can get embryos on their way that are stuck. You can get embryos that lead to, I'm sure the residents are well aware, that can lead to ectopic pregnancies. And also, the fluid itself is abnormal. So this was a study done in 2006 looking at cells from tubal specimens and cells from the endometrial specimens of women with hydrosalpinges. And what you can see is that just the total inflammatory cells is markedly increased in both samples, meaning that the fluid was actually having an effect on the endometrium as well. You have tons more lymphocytes, you have tons more neutrophils, a lot more plasma cells, and even more macrophages and whatnot, at least in the tube, versus endometrial specimen actually was less macrophage. Then, when we look at the hydrosalpinx fluid, we understood from research that was going on was that the fluid is probably embryo and endometrial toxic. And evidence from donor eggs and donor embryos in IVF, when we were taking donor eggs from women who had successful pregnancies and then putting them into women who maybe had a hydrosalpinx, they were having not great outcomes. And then when you actually take the tube out, their outcomes dramatically increase with the same donor eggs and donor embryos, for example. So that was an indication that something was going on with the tube that was making it toxic to the environment of the uterus. But also, as eggs from that potential person who does have the hydrosalpinx comes through a tube, if they're doing it autologously, those eggs are actually also considered to have some issues going on as they're developing into an embryo throughout the tube as they kind of traverse that over those 5 to 6 days before implantation. We see an increase in primary inflammatory cytokines such as IL-2, 8, 12, alpha, and TNF-alpha. This is actually a stain for IL-2. Looking at glands in the hydrosalpinxes, and you can see that the staining is so much more intense when you're looking at that versus a control. You also have a decrease in integrins, leukemia, inhibitory factor, which are very, very critical for implantation and kind of how trophoblasts attach to cells and move along throughout the stroma. So that's very important as well, and those have been shown to be decreased, especially during the window of implantation, which is the prime time for an embryo. How do we treat it? Well, that depends on is it patent and what else is going on. So we screen first with an HSG or with something potentially like a FEMU, although an HSG will be better for diagnosing the specific cause of like a hydrosalpinx. But the definitive diagnosis is actually a laparoscopy with chromoperturbation. So what we normally do, if we think we may take out a hydro, we still consent for doing a diagnostic laparoscopy, chromoperturbation, and a salpingectomy if needed. That way, we just don't want to see one more time, is the tube open? Is it actually patent? Was there potentially just like a spasm on the HSG or something like that? Because if it's patent, it actually may not need to be removed. If it's occluded, we likely would remove it for everything. Remove it for IUIs, IVF. Obviously, if we're removing it for IUIs, you need to have at least one open tube available. So it can only be unilateral, but for IVF, we would just take it out due to the toxicity of the fluid. If they're patent, we probably wouldn't remove it for IUI. Give them a couple chances to try and see what happens. For IVF, depends on the distance away from the cavity of that hydrosalpinx, depends on the length of normal tube, depends on have they tried before, do they only have like one embryo potentially to transfer back and this is like their only shot? Are they already on the donor pathway and spent a lot of money and really just want to take care of this? So a lot of things that come into play for IVF if they're paid. This right here is a picture showing how actually taking the tube out actually does help on a immunological level. So NF-kappa B, with P65, which is a cytokine, is decreased after a salpingectomy compared to control. So before a salpingectomy, you'll have this large increase in this marker. After salpingectomy, it has been now brought down to the aspect of a fertile control in the endometrium. Moving on to endometriosis, it actually can be thought of as an immunological problem in the first place, which I honestly did not know until I started doing research in this field. But retrograde endometrium, if you think about that whole theory of endometrium kind of coming out during menstruation, it actually usually is cleared in the peritoneal cavity by immune cells in normal healthy individuals, by scavenger cells of macrophages, NK cells, and T cells. However, when this doesn't happen, potentially from a dramatic increase in these stromal cells, which can show up in the presence of ectopic endometrium in the peritoneal cavity, they could actually induce immunosuppression and the endometrium getting past this immunosurveillance. You could have impaired NK cell activity, you could have decrease in the phagocytosis of macrophages, you could have induction of T regulatory cells, and this is all involved in helping the endometrium further escape peritoneal immunosurveillance. There's also cytokines such as ICAM, IL-6, IL-8, VEGF, that might be released from this ectopic endometrium as it's growing kind of unbothered, and that can cause some also immune issues and then contribute to issues with adhesion, invasion, angiogenesis, and growth. Then these cytokines and autoantibodies that are kind of produced during all this mess change the cellular and hormonal immune response in the cavity, the follicular fluid, and the endometrium, and can lead to decreased fecundity, infertility by decreasing the endometrial receptivity. They can reduce the oocyte quality, sperm mobility, and as well as cytotoxicity for the embryo. We see that endometriosis affects early pregnancy and IVF. So just looking at studies that did like meta-analysis on outcomes before any IVF treatment or anything like that, women with endometriosis were found to have at least a 2 times risk of miscarriage. And then for when IVF outcomes were actually looked at, it was just affecting things across the board. Anything from pregnancy rate to fertilization rate to implantation rate. If it was just by itself or if it was combined with other stuff, it would just make it worse. So how do we manage this? Well, it kind of depends. Endometriomas, we don't really care that much about, to be honest. It's more of a symptomatic thing. It's more of a where you're trying to prevent you from getting ovarian torsion thing. Research has found that if you actually excise an endometrioma, you're looking at potentially a negative impact on ovarian reserve from the surgery and taking out good ovarian tissue, which could then also lead to longer stimulation, higher FSH requirement during stimulation, and lower oocyte count in some, without getting any improvement in IVF pregnancy rates and ovarian response to stimulation. So kind of why bother doing that? If there is endometriosis in the cavity or in the pelvis or on something else, and that those could actually be ablated or resected to restore pelvic anatomy, which may help someone who's trying to do something like IUI and needs their tubes open and trying to avoid adhesions, also for symptomatic things such as pain, for example. What can help is hormonal pretreatment. So one of the first go-tos was combined oral contraceptives, giving that for 6 to 8 weeks before IVF or ICSI, another form of fertilization, in women with endometriosis by suppressing their menstrual cycles. So normally you have endogenous GnRH receptors that are functioning and releasing LH and FSH, but these would also grow the ectopic endometrium. So if we can give these hormones to just suppress all this stuff going on, you get this hypoestrogenic state, which hopefully doesn't lead to proliferation of the endometriosis. So then people thought, well, what about these GnRH agonists, such as Lupron, Depo, anything like that? Could those be even better? Now, the research on that actually kind of goes back and forth. It's actually gone back and forth so much that things like Cochrane reviews have been redacted and stuff like that based on making some crazy claims. But some professional groups actually have continued to recommend suppression with GnRH prior to IVF, especially in Europe and whatnot. But the US, actually, the ASRM has not recommended it all the time yet. And there's no consensus in how long you do it, 3 months, 6 months, 1 month, or which aspect of infertility is best treated. Are you concerned about fertilization? Are you concerned about implantation? We don't know with suppression which one of those is best affected. There's a new drug on the block, and this is elagolix. May have heard of this. I hope you have. It actually has been shown to be pretty great in what it's doing. Instead of someone taking a shot as a GnRH agonist, you could take an oral small molecule GnRH receptor antagonist that is dose dependent and can lead to either partial or full suppression depending on what you'd like to do. Anywhere from 150 milligrams once daily to 200 milligrams twice daily. And the pain is decreased by 4 weeks. It's well tolerated with less pronounced hypoestrogenic effects. Only the half-life is 4 to 6 hours. And when you stop it, you actually see a rebound of hormones within 24 hours, which is pretty great. There's a couple of RCTs open that actually are looking at this in the IVF aspect, either before IVF and before stimulation or before actually transferring an embryo back. And so these are kind of ongoing. This is really one of the, Yale actually, where I was coming from for residency, was one of the people helped make the drug and actually are leading the trial. So it'll be pretty interesting to see kind of what's going on there. Thinking of adenomyosis, it's actually good to think of it as just endometriosis, like little cousin. It has these ectopic endometrial glands in the myometrium that are, again, usually dealt with by just a regular immune system. But when they pass immunosurveillance, they create problems. It's generally viewed as a chronic inflammation, just like endometriosis, but more of a low-grade inflammation as opposed to so much stuff happening as with endometriosis. You get inflammatory markers that are increased that lead to immune dysfunction and decrease in Treg cells. You get altered uterine vascularity. You can get abnormal endometrial gene expression, which can affect receptivity, cellular abnormalities, and then you can get dysregulation of endometrial expression of sex hormone receptors, such as the progesterone receptor and the estrogen receptor in the stromal cells, which can lead to problems with decidualization, problems with spiral artery remodeling, and things like that, because those are what they're used for. Originally, adenomyosis was called a disease of the multip. I didn't know that until very recently, because they didn't notice it until they were looking at women who had had multiple pregnancies. So it was like, oh, this isn't something that you have to worry about for infertility, because this is something that you get as you deliver and have multiple kids. But then looking back at meta-analyses, it was discovered that just having adenomyosis actually did lead to a decreased pregnancy rate and an increased miscarriage rate as well, even in no-lips. The treatment would be suppression if you wanted to do something about it. However, it isn't as strongly recommended. We don't know how that much. It's more of like a last resort or very case-based, like I said before. Are they older, only have like one embryo left, trying to do everything that they can type stuff. Moving on to chronic endometritis, something I feel like is a little bit more new in the fact that everybody's definitely treating it. But chronic endometritis, we believe, occurs when there's an imbalance in the microbiome of the woman's reproductive tract. We have no idea what the specific balance is supposed to be, as shown in this table over here. You could have, especially for fertility, that is, you could have bacteria that are in there that actually still keep a woman fertile, even though they might have endometritis that we see. And in the infertile population who have chronic endometritis, there's just a whole slew of sometimes other microbes, sometimes not. The only one that kind of pops up that's higher in this one, for example, and not in this one at all, is really mycoplasma. But there isn't a dominant one pretty much that you're looking for. It's just that whatever this imbalance is, we believe that it creates the original makeup made some homeostasis for the woman, and that was normal for each woman. And when this is disrupted either by ascending or descending pathogens, this can lead to endometritis, which could actually explain why it's usually asymptomatic, we feel like. So when the imbalance occurs, you get an increase in plasma cells due to which can increase IgA towards new antigens. You get a decrease in uterine NK cells, and these are uterine NK cells, which are normally actually pretty abundant in the endometrium, actually have less toxicity than plasma NK cells. But if you lose that, then you actually get more cytotoxic NK cells, and so that's a problem. This froze. Oh, there it goes. And eventually you get an increase in macrophages, an increase in B cells, and then that leads to just this inflammatory endometrium, potentially of chronic endometritis. And because the antibodies are now present, you can actually expect the immune cell environment to change and then more things to happen. And we're not even talking about really just immune issues. We're talking about other things such as vascular changes, altered uterine contractivity from more cells being in there and creating aggregates, which just makes muscles not do what they're supposed to do when they contract. So there's a lot of things that could happen with endometritis. Like I said, it's usually asymptomatic. You may get some subtle symptoms, such as, or women may get subtle symptoms such as spotting, increased discharge, pelvic pain, cramping. And this is diagnosed by the presence of those plasma cells that are CD138 positive. These have a high prevalence among infertility patients and unexplained infertility patients. We see about 40 to 55% of them may have chronic endometritis. Recurrent IVF failure anywhere as high as 67%, and recurrent pregnancy loss as high as potentially 67%. And the management is actually pretty simple. It's really just like a couple antibiotics for about 14 days. And we do a test of cure usually to make sure that it's gone. All right, moving on to fibroids. Really a topic of discussion over the past few years. Type 0 and 2 are no-brainers. I mean, these are like 0 through 2, I'm sorry. They're in the cavity. When people work so hard to make embryos, we don't want them to get any messed up by these fibroids that are sticking in there that could A, make an embryo not implant in the first place, or B, not enough blood flow to where they miscarry early on. However, type 3s, where they're contacting endometrium, but they're not really in the cavity, what do we do about those? So there has been some stuff to show that they may alter some things. That's because these stromal cells surrounding fibroids actually do have a really important job to do. They regulate the Hox genes, which are homeobox genes, which help embryo development, especially HOXA10, HOXA11, leukemia inhibitory factor, which is really important also for implantation and predecidualization, and BMP2, which is a multifunctional growth factor that regulates the expression of Hox and LIF. However, it's known that TGF beta-3, another cytokine, actually reduces the expression of BMP receptors in stromal cells, and this cytokine is actually expressed by fibroids. So could fibroids be doing something? So what the hypothesis is that increased TGF beta-3 from a fibroid decreases the BMP receptors, which leads to a decreased response to BMP2 and then impaired expression of these Hox genes, even if it's just pretty close. If it's farther away, probably not, like a type 4. If it's a type 2, most definitely we actually do see this. How is this actually studied? Really interesting study, again, out of some people from Yale. My old chair, Hugh Taylor, is doing great. But he did this really interesting study where he looked at hysteroscopies of people with known submucosal myomas, would take an endometrial biopsy right above it, so that's the SM. Would take an endometrial biopsy somewhere else in the cavity for those same people, that's the DSM. Those people with submucosals, not in the cavity, but just taking it somewhere else. And then taking an endometrial biopsy above an intramural fibroid in different patients, and then taking endometrial biopsies of controls. What he looked at was the HOXA10 and the HOXA11 mRNA, and saw that directly above a submucosal myoma definitely decreased, and even endometrium far away from a submucosal myoma actually still decreased significantly, but above an intramural fibroid, not decreased, and still similar to the controls. Showing that there definitely is something happening with a submucosal myoma, even to the point where if it's somewhere else in the cavity, so pretty interesting. And this is just now immunohistochemistry staining of the HOXA10 mRNA. Yeah, absolutely.
How do you know if you're at the spot of an intramural fibroid? Were you doing ultrasound at the same time?
Yeah, so these were diagnosed by MRI. I'm looking for a good, I forgot what they had some cutoff for amount of regular myometrium that they wanted to see before the endometrium. Basically, also, if you see the endometrium touching that fibroid, it would count as a type 3 anyway. If you see really any amount of myometrium, it counts as a type 4. Other things that they were looking at, HOXA11 and BTED1, which are things along those pathways as we discussed, very similar. You're looking at dysregulation where right above a submucosal myoma, you see dysregulation, while above intramural and in controls, there is nothing. That's what you're comparing it to, and it's different from those. Now, trying to look at now what is actually happening, they actually looked at now myoma condition media. So they would take these submucosal myomas, they would take their cells, take a couple of them, just culture them in a dish, drain out the media, put that media onto other endometrial stromal cells that were actually normal, and saw that that media alone would create dysfunction. Again, showing that it could just be a paracrine effect by just being nearby. It doesn't even have to be touching it. There was confirmation that the TGF-beta3 levels were elevated in the biomyoma conditioned media, and then exposing those stromal cells to the media with the TGF-beta blockers could either increase the BMP receptors back up to normal, or if you didn't have the blocker, then it actually caused the problem that you were looking for. But still, the research is still going back and forth, and this was actually a fertile battle, which is really just a pun on people disagreeing and having an argument in the journal. But going back and forth on should they be surgically removed or not. And it was going back and forth, and there's still no consensus as to what should be done. They actually based it more on size because they think that also the amount of TGF-beta3 that could be secreted from these fibroids may also be based on size, and you kind of just don't want to leave a big one there because who knows kind of what it's doing. Going on to alloimmune issues, so no, man, this is the line I hate the most in any paper I read is that more research is needed. It's like, when is more research not going to be needed? But okay. So alloimmune issues are the immune response to non-self antigens from members of the same species. So that means basically how does the mother respond to antigens passed on from the father or the paternal contribution of the embryo, because that's really the only thing that's going to be foreign to the mother potentially. Normal pregnancy requires maternal immunologic recognition in response to paternally derived antigens and on embryonic tissue in an appropriate fashion. That way it doesn't kind of abort the embryo. You know that abnormalities in the maternal alloimmune response may predispose to recurrent pregnancy loss by producing cytotoxic antibodies and cytokine dysregulation of the immune mechanism at the interface. 15 to 20% of women with recurrent pregnancy loss actually have abnormal T helper cell lymphocyte responses to trophoblast antigens in vitro, presumably we believe to stuff that the paternal origin passed on, while less than 3% of women with normal reproductive histories have this problem. And there's some increased IL expression in placental tissue from women in recurrent pregnancy loss, which could be a primary event or a secondary event if that's was something already happened to the embryo, maybe leading on to miscarriage. We don't know. Something that's really interesting, though, is the alloimmune issue that could be potentially one of the factors of preeclampsia. So I don't know if you've heard of this theory. It's quite fascinating, but there are some unique preeclampsia risk factors, such as young age, new partner, getting pregnant by ICSI when somebody couldn't have any sperm production, so they were basically an obstructive vasospermia. And potentially this is all because of just decreased sperm exposure. They haven't had intercourse many times or at all, or seen sperm that often. And unfortunately, the maternal immune system is just not exposed to the sperm, and thus, if you have repeated intercourse, though, and supply a cytokine environment with an antigen, you actually may make the mom kind of get used to that sperm and actually stop fighting it later on. So research has been done on this and shows that there is an antigen on sperm cells itself, and that a cytokine environment that's created from the seminal vesicle-derived TGF-beta1 together actually create a post-mating inflammatory response that could potentially make the mom kind of see these sperm cells and the antigens on the sperm cells and then not create actually, and just kind of tolerate these sperm antibodies that are coming on. And that if they don't do this over a few times, then that could potentially lead to preeclampsia later on. Pretty wild if that's the case. Additionally, alloimmunity is processed by these things called major histocompatibility complexes, or MHC molecules. So these are genes that are on the short arm of chromosome 6 that basically present antigens to other immune cells. Class 1, think of it as me reaching into my own pocket, pulling out some money that I had and being like, hey, is this my money or not? Is this good money? While type 2 are me going around the room, taking someone money from everyone else and being like, hey, is this good money or not? So type 1 is looking for things inside your own cells. Type 2s look for things outside of your own cells in the environment. Between these, they can actually sample pretty much every protein in the human body and present them to other cells and be like, hey, analyze this. Is it me or not? Should I kill it or what? And then kind of go from there. What can happen with these? Well, a lot of things. So cytotrophoblasts and cystotrophoblasts that are right on the embryo actually are devoid of these MHC molecules. So they don't even present anything. They don't want to create any havoc. They're like, leave us alone. While EVTs and endovascular trophoblasts, so EVTs are extravillous trophoblasts, they're doing the invading, they are not devoid of these. They actually do express HLA molecules. They actually do want to present. And in a sense, they actually are presenting a lot of HLA-G and HLL-C that we'll get to. But HLA-G, what is a marker for actually EVTs, interacts with these uterine NK cells to really tone down the immune response and just tell the body, hey, don't attack this. This is actually only expressed on placenta. So if you can leave this alone and let this embryo kind of do what it's doing, then that'd be great. Thanks. However, when we see gene polymorphisms between HLA-G and women, we see potentially recurrent pregnancy losses. And if there's an HLA-G polymorphism, it could actually decrease uterine NK cell cytotoxicity. Increase it by normally it's supposed to decrease it. So if you have low levels of this, you could increase the risk of fetal loss. Also, how the embryo or how the NK cells will recognize the HLAs, especially the Cs from the EBTs, has been shown to potentially shown issues with lack of invasion. So remember how I talked about these NK cells, they want to suppress immunity? Well, also at some point, they need to create an immune response for spiral artery remodeling. This has been shown to be actually necessary for this remodeling aspect. And so you could say inflammation, again, is a good thing that's needed. So you do have to turn on your uterine NK cells at some point. And what's been shown is that certain HLA-Cs, if they don't match kind of what the mom has, and there's some specific combinations of HLA-C2 and these receptors and their haplotypes, if there are a lot of different combinations or potentially bad combinations, that potentially you get a pathogenesis of defective arterial transformation, which could be seen in preeclampsia, fetal growth restriction, recurrent pregnancy loss. And so you have more incidences of abnormal placentation. So treatments for these alloimmune things, a lot of people just jump on what's called the suppress express. Let's try IVIG, let's try intralipids, steroids, GCSF, low molecular weight heparin. But I've been talking to you about how inflammation is a good thing. So why would you really want to suppress it? Do we really need to do that? Because sometimes you actually need it and it may not work. But this is why really the treatment for autoimmune disorders just isn't there yet. In our practice guidelines from ASRM, IVIG, it says that don't do that because while it may improve the implantation rates on some studies, it's not significant enough for ongoing pregnancy rates, and so it actually is not recommended yet. There's intralipid, which to be honest, is just weird. If you actually read about what it is, you're injecting fat emulsions into people's veins, and so it was shown at some point to potentially increase the amount of good NK cells that we have that women have in their uterus. However, pregnancy rates and live birth rates don't change with intralipids, so not really a thing that's recommended. GCSF actually may eventually be a real thing. Its activation is needed for spiral arteries through NK cells that I was talking about before, and there are actually RCTs in progress that may actually be showing some promise, so stay tuned. It should come out in like 2 years or so. Regardless, the lack of info and treatment won't stop capitalism. So you're going to see all these things of like, hey, straight, just get your answers for unexplained infertility. We can tell you everything you need to know. Yeah, sure, right, okay. And actually, if you look at these things, most of them, it's pretty sad. Most of them are already in the workflow. By the time somebody has recurrent pregnancy losses, I mean, your patient history, I hope, is flushed out. So I don't know why they care about this. And now they're just paying for more testing. Hopefully done thyroid test by then. You've hopefully done like an AMH, an insulin, a fasting glucose, testosterone. You've hopefully done that. Hopefully look for some thrombophilias already. Really, it's only testing like a couple of things. And those couple of things, research isn't even really great on. So these HLA mismatches, these HLA-C antibodies. I mean, if I told you, hey, this is high, what are you going to do with it? There really is no treatment yet. So it's kind of tough. It's kind of tough to do. People pay for this out of pocket. No insurance is not going to cover it. But it's unfortunate when they do pay for this. So many questions remain, I think, but we are on our way. And I think the coolest part of Grand Mountain is when people do their own research. This is actually my research, or part of my thesis and fellowship that I'm still working on and kind of taking on to the next level. So this is a microfluidics chip that we have 3 chambers, an EBT chamber, a chamber of extracellular matrix, and an endothelial cell chamber. And we can make it so trophoblasts can traverse over through the extracellular matrix onto the other side by just putting them close together. And what my research was focusing on, actually with my wife, who's a reproductive immunologist over at Penn, is like looking at these and introducing cytokines. You could put immune cells in the matrix and see what all these things have on the impact. But really the goal is to show you that our models were terrible back then. I mean, research in reproductive health is just awful. Ethically, it's hard to do, and kind of modeling is hard to do. But as models progress, theories will be confirmed, therapeutics will hopefully improve and be studied and discovered. So I think this is just showing that people are on their way to try to figure out really what's going on. And already there are great strides that have been made with reproductive options, and we always try to weigh the risks, benefits, costs carefully while we keep these in mind, while keeping the ultimate goal in mind, which is helping women have a family. And with that, then I will take any questions, and thank you again for having me.
Thank you so much. That's awesome. Can you speak to the current landscape of research looking at COVID as a pro-inflammatory state as it affects recurrent pregnancy loss, or what we're seeing right now? I feel like there's a lot of talk about that in general.
Sure. So we think of it, at least in the REI field, as more of a systemic inflammation going on. Long-term wise, not sure if it has anything, but definitely around the time of implantation, any inflammatory response would be terrible. So we did see increased risk of miscarriage and increased problems there. At some point, while research with the vaccine showed nothing happened, when it first came out, people, even anecdotally, were like, if you could avoid even the second shot around the time of a transfer, we don't want that, because people were getting some responses actually to the vaccines, and so we would try to avoid that too, just through that increased inflammatory response. So it's more of a systemic thing. We are pretty positive, well, I was thinking of a different disease, but not really much to do about that besides just kind of wait for it to pass. We don't think it has any lingering effects on implantation, and hopefully it's cleared appropriately. And we actually haven't seen anything in terms of long-term aspects with COVID, so hopefully it's not something we have to worry about. But definitely at the time with stuff going on, yeah, too much happening, immune chaos, not good.
Very nice. On the antiphospholipids, you're using low molecular weight heparin. Do you use your oral low molecular weight substances, or do you just use the injectable?
We use injections, yeah, 40 milligrams usually, at least once, sometimes twice a day. But yeah, we still use injections. I don't know anybody actually using orals yet.
Like Eliquis or any of those? No. And secondly, on the anti-sperm antibodies, you're using, I didn't think you mentioned it, but using any steroids for that?
No, good question.
Well, back where you trained many years ago, Gil Haas did the study with the anti-sperm antibodies, and they were using steroids then. It's like in the early 80s. Are they doing anything like that now?
I actually haven't seen a positive anti-sperm antibody in a long time, so I couldn't even tell you right off the top of my head what would be my first go-to. So I'd have to ask somebody, but I'm not entirely sure even what I would do with that. I have to look into that. I haven't seen it in so long. I'm not sure about the treatment. Anything else?
Congratulations, wonderful question, Dr. Simoni. Vince Bergella from MFM. I have a quick question on the genetic side. Years ago, we did a study with the fellows on losses at like 6, 7, 8 weeks that were practicing CVSs, and I was somewhat surprised and whatnot that we had a 75% of abnormal karyotype on those early losses. Those were occasional losses, but 75% of them had abnormal karyotype. We didn't do microarray or exomes. This was just a straight karyotype. And I wonder how this whole inflammation, infection, and stuff you think interacts with those genetic losses, because especially as we have better ways to detect genetic issues, with exome sequencing, et cetera, I would think that will be another area that will be, interesting to study. I know that you studied in IVF, with normal embryos versus aneuploid embryos. So could you expand on that and how it interacts with what you talked about as well? Sure.
So is your question kind of like if you have an aneuploid embryo, putting it inside, that could create an inflammatory response? Is that what you're asking? Yeah, and if you think that the genetic part also with more exome sequencing will be will kind of put a dent in those unexplained recurrent losses. That'd be hopeful. I know. I mean, I'm so used to testing products of conception to look for that, and even when we have euploids that miscarry, we still test for. We still want to get the products afterwards just to make sure we weren't wrong in anything like that. I'm not sure if exome sequencing will help. I think already with the PGTA that's done. Granted, you have to be going through IVF for that. But with that being done, hopefully we do decrease that. If the exome sequencing can get to that before or without doing PGTA, then that would be nice too. But I don't know about exome sequencing in itself. I'm not too familiar with that. But definitely the fact that you have abnormal embryos, while most of them miscarry at some point, I mean 99% of them or so, we do believe that just being abnormal potentially can create these inflammatory responses and even miscarry before the embryo wants to miscarry, for example. That sometimes the body recognizes that something is going on and will actually just abort it itself. And we also see, obviously, embryos just stop growing in culture when we're doing it in the lab, but still believe that it's creating some sort of wrong environment for that going on. Reason also we believe that if you put two embryos back together and one of them is potentially aneuploid and causes this inflammatory response, that obviously that can harm the good one if that other one is good. So why also we could pretend to want to do one at a time just to not increase that risk. So hopefully you have a successful pregnancy.
Thank you.
Has anyone looked at the impact of stress on endometrium and the immunologic landscape?
Well, sure, that's like a cortisol thing. We do know cortisol affects a lot of things. Mostly when we think of stress, it's more either the ovulatory process, unless you're talking about so much increased cortisol from either it's creating actual inflammatory responses like increased CRP, something like that. I would say also though tend to see that for more obesity or biological reasons like diabetes or something like that. I don't know specifically cortisol in the endometrium from stress. I'm not sure about that. Women do ask that all the time, and I tend to be like, are you ovulating? If you are, I would actually not hang so much on the stress itself. But I mean, anecdotally, it's hard for so many women who come in like, that was not a good time in my life, going through deaths, divorces, whatever. So job stuff too, obviously. So it's hard to be like totally, yeah, that's not an issue. So I'm not sure. Yeah, that's not definitely set in stone. All right, well, thank you, everybody. Appreciate it. Any questions, feel free to email me later on. That too.
I'm keeping my head above the nascent
I
dictionary.
literally gave up. I gave up. Literally, that's how I felt after about 2. I wish I took it after like 2 weeks because that's like when I was at my prime and so like
Please join Michael
like
Simoni.
I thought because like she was like I was pregnant until this one.
Great.
I just like
People with a lot of problems, but
and like I just was so weak. Like I just
Yeah. That's my friend out there.
perfect position.
He is ED.
I can't do all this myself. I don't have an NA.
You're gonna be like,
I don't have a nurse practitioner.
research like basic science on it.